Today by not only one, I'm joined by not only one Charlie today, but two. And before we jump into the slides, I'm just going to ask both of them to quickly introduce themselves. So Charles or Charlie McGrath, could you go first, please?
Thank you, James. So I'm Charles McGrath. I'm a patient advocate with Alan. I'm a member of the steering committee. I myself was an AML patient a couple of years ago. I was diagnosed in September 2022. I'm thankfully now in remission. And as part of the steering committee, I'm very keen on highlighting the impact of acute leukemias, particularly on younger patients, on adolescent and young adult patients, and also investigating the possibility of kinder treatments for people with acute leukemia, which I'm very glad that this webinar touches on today. Thank you.
Thank you, Charlie. And then, Professor, if we could get a quick introduction from you.
Yeah, hi, everybody. I'm Charlie Craddock. I'm a leukemia clinician in Birmingham. I'm passionately committed to ensuring that patients access new treatments and effective treatments. I've just stepped out of clinic. I'm going to have to go back in 20 minutes for a patient who had relapsed and refractory acute myeloid leukemia, who went on to a study of a menin inhibitor, which we're talking about in a minute, and is in remission, and he's had a transplant and is likely to be cured. So I think it's extremely important that we are opening up access to new treatments for patients whose outcomes are otherwise not good. And to that extent, I've worked with colleagues to establish clinical trial networks in the UK in both AML and transplant, with the aim of attracting new drugs. And in fact, we are attracting a menin inhibitor to the UK so that UK patients, it's very important to remember that this is a time of great hope for patients with blood cancer, but only if we can connect them with these new treatments. So thank you for the opportunity.
And thank you both for those introductions. And again, thank you for your time. Before I forget, my name is James, so I'll be helping with the moderation of this session today. For those of you at home, the way that it will be structured, it will be an hour long. There will be two presentations, one on menin inhibitors in AML, and as Charlie said, some key breakthroughs there. And then the second one will be on advances in ALL. Both will be followed by a Q&A from our audience, so please do get your questions submitted. As Professor mentioned, he's kindly joined from practice today and will need to leave early. So any questions that don't get answered, we will be following up offline. So please do continue to get your questions in. On that note, as discussed, there is a Q&A session, so there will be two today. To ask a question, there is a Q&A button towards the bottom of your Zoom window. If you have any technical issues at all, please just drop a note in the chat and someone from my team will be able to reach out to you to support you. And finally, the session is being recorded, so if you need to step out or you miss anything today, everything will be available on Alan's website after the webinar. Quickly then, so the purpose of today's webinar is to really communicate some of the complex medical information and findings from the recent ASH conference in a format that is easily understood. This webinar does accompany reports and infographics, which can all be found on Alan's website. So if you have time after the webinar, please do go and check those things out. Before we jump into the presentation, we just wanted to level set. So there are some terms that you'll see throughout the webinar today that will be used. Charles McGrath, I might just go to you on this one. If you could just walk through these key terms.
Absolutely. Thanks, James. So I'm sure most people in the audience, if not everyone in the audience, is vaguely aware of most of these terms, but I will run through them. Obviously, complete remission means that there are no signs of any leukemia cells in either the peripheral blood or the bone marrow. Relapse, obviously, is when leukemia or any type of cancer comes back after a period of time. Refractory means treatment-resistant blood cancer, in particular, leukemia. Measurable residual disease is all around the presence of leukemia or potentially leukemic cells within the bone marrow that are left over after any treatment. And MRD negative is when there is no presence of any of those cells in the blood or the bone marrow, detected by very sensitive tests, including PCR testing or next gen testing. So that's a very, very granular level, and normally people who are in MRD negative positions tend to be disease free for a lot longer than people who are MRD positive. But yeah, those are those key terms there. Thank you, James.
Thank you very much, Charles. And then, Charlie, if we could just hand it over to you, please, just to start your presentation.
Yes, thanks so much. And thank you very much to the Allen team for all your work. This is so important, the initiative that you're leading, to be congratulated. So I'm going to give you a quick update of some work presented at the recent American Society of Hematology meeting in San Diego. Big meeting, 30,000 clinicians, people from pharma companies, patients, all trying to think how we work together to improve patient outcomes. And one of the most interesting new developments in the management of acute myeloid leukemia is a class of drugs that people may have heard of called menin inhibitors. So this is now a new treatment option for patients with particular molecular subgroups of acute myeloid leukemia, and it's originated from fundamental basic biological research stemming back for about 15 years by a brilliant man called Scott Armstrong in the United States of America. And Scott Armstrong was able to identify that there were particular disruptions in molecular subgroups of acute myeloid leukemia that contributed to the patient developing the disease. And he was therefore able to demonstrate in collaboration with drug companies that you could block the protein menin, which was driving the leukemia. And so these menin inhibitors were shown in mouse models to be effective. And we're talking today about the very exciting clinical evidence that they're also helpful in the two main subsets of acute myeloid leukemia that are targetable, in which menin plays a key role in disease biology. And this is a relatively rare population of patients with AML called, they've got rearrangements, changes, mutations in the KMT2A gene. And then there's also a commoner gene called NPM1, which is mutated in about 30% of patients with AML. And these patients also seem to respond well to menin inhibitors. Next slide. So the real promise with these drugs is that they appear to be able to take people with acute myeloid leukemia who have active disease and in vivo, in the body, that you can block the activity of this menin, and that results in patients going into remission. So let's look at that data now. Next slide. So the data came from a pivotal study of about 80 patients with relapsed or refractory acute myeloid leukemia with this particular molecular abnormality, KMT2A. And what was shown was that patients with active disease, for whom really probably there were no other effective treatments, treatment with a menin inhibitor called revumenib, there are now at least 4 of these particular menin inhibitors, put people into remissions. And the results were so striking that although it wasn't a randomized study, it was just a single-arm study, the FDA, who set very high standards, were satisfied that the drug was both safe and effective. Next slide. And so what we saw was an update at ASH of this pivotal study. And then, as we'll discuss in a minute, particular new areas for development of this very promising new agent. Remember, when you're developing new drugs in leukemias, you typically start with evidence of activity in patients with active disease with relapsed disease. And then if it shows tolerability, it's safe and it's active in that setting, we think about taking it up front. So next slide, please. So this is the pivotal study. It's called Augment, and 116 patients, adults, average age of 35. And these are patients who had recurrent disease or had actually not even gone into remission after having an average of 2 previous treatments, most of them intensive chemo. So what you want to look at in these early phase studies of any new drug is the drug safe? And is it active? Next. So what they were able to show in this study was remarkably that these patients with relapsed and refractory disease, 23% went into remission and 64% had evidence of a major clinical activity. And interestingly, so Charles at the start of this presentation gave a beautiful summary of our leukemia acronyms. He summarized it beautifully, and he talked about measurable residual disease. That's a very sensitive measure of whether leukemia is there. It's much more sensitive than our conventional measure, which is just looking down a microscope. And interestingly, a significant number of the patients who were in remission also had no evidence of detectable disease. So that's really good. Next. And importantly, broadly, this was a safe drug. It's not uncommon when you have patients with relapsed or active leukemia that you have fever or you have anemia. And so the presence of those side effects is not in itself remarkable. What was important to look at was whether any non-hematological toxicities. And they did see that in a small number of patients, as the leukemia responded to treatment, the abnormal leukemic cells differentiated, progressed through to normal white cells, and you had very high levels of normal white cells in some patients. In and of itself, this is not a bad thing, but when that happens quite quickly, it can make patients feel unwell with fever, shortness of breath, weight gain. So that was present, and as clinicians got used to the looking out for this and treating it more effectively, it was found to be less of a problem. And there was a small number of patients in whom one of the ECG tests was abnormal, although this didn't result in any significant cardiac toxicity. Next slide. So the key takeaways are this is a new drug for treatment of relapsed refractory leukemia. The updated analysis confirmed the activity and that this is a deliverable agent. So this is a real breakthrough. Next slide. Similar data has shown activity in patients with a mutation in the NPM1 gene. So it looks like we're moving with a class of 3 or 4 of these new agents, likely to get approval from the FDA, and we hope the European regulatory authorities for treatment of relapsed disease. The question now is, can we actually think about taking this new treatment up front or combining it with other new active drugs in leukemia? And one of the most active new drugs, particularly in older patients with acute myeloid leukemia, is venetoclax. So what we saw in this study was a combination of revumenib with venetoclax and an oral version of azacitidine called decitabine. Next slide. So again, these were patients who'd had disease before, predominantly, although there was another presentation in patients with newly diagnosed disease. And what you're seeing is impressive response rates and encouraging survival in the short term. These are very new studies, and we need to look at longer term follow-up. Next slide. So again, the side effects were pretty tolerable. There were some issues with nausea, some changes in liver biochemistry, but none of these caused particular issues for the patients. Only one patient had to stop treatment. and one patient did die whilst on treatment. Whether the new drugs contributed to that or whether it was leukemia itself is not clear. Next slide, please. So this slide really, and this presentation, part of the presentation, is to demonstrate that we are anticipating these menin inhibitors will become even more effective when combined with other drugs. And it would appear that it is possible to combine them in the relapse setting. And as I said, there is now encouraging upfront data with combinations such as this, so that there are large randomized studies now planned and about to recruit, looking at giving menin inhibitors upfront in combination with venetoclax in older patients with newly diagnosed AML, or actually in younger people in combination with chemotherapy. And I was on a call with a drug company from the States yesterday about a UK study, which I think will be the first in the world, giving these menin inhibitors, in this case enzomenib from Sumitomo, post-transplant, with the aim of improving transplant outcomes. I think that's my last slide. Next slide. Yeah, well, what's next? I think I've covered it. We've got new menin inhibitors look equally promising. They're listed there. Similar results. It's impossible to say if any of these are the best, but the most important thing is we've got at least four new drugs. Next slide.
Thank you.
And I think I've summarized this already.
Yeah.
This means that we're moving towards new treatment options, not only for relapsed patients, but potentially for newly diagnosed patients. So I think I'm happy to take any questions that people may have at this stage.
I don't believe we've got any questions at the moment in the chat, but can I start with one, Charlie, please? Yep. So obviously, one of the really interesting things about these menin inhibitors is that some of them, at least, seem to be oral treatments and potentially treatments that the patient could take in an outpatient setting, as opposed to intensive chemo, where, of course, patients tend to have to spend quite prolonged periods in hospital. What I suppose, obviously, there's obvious mental and well-being benefits to that for patients, but could you elaborate on perhaps some of the, I don't know, some of the mental and well-being benefits to patients, certainly patients who are eligible to take these menin inhibitors, who have relapsed or refractory disease, because I think that's a really important thing for patients, isn't it? The fact that they wouldn't necessarily have to be in hospital for long periods of time as an inpatient for this treatment.
Yeah, I think it's a great point. My perspective on this is the most important thing is to find active treatments, whether that requires inpatient stay or outpatient stay, because the alternative for these patients with relapsed disease, there isn't an alternative, and it's just palliative care. If on top of that, we are able to deliver these agents as an outpatient, that's great. And that, I think, is potentially a very attractive feature of these studies. But I think at the moment, the real challenge for us all is to say, okay, these are looking promising in patients with a KMT2A mutation or an NPM1 mutation. Are we able to find similar active drugs in different subgroups? And at the moment, that's an area for active research. But you're absolutely right, Charlie. We will be using oral agents moving towards outpatient therapies. Thank you for that.
That's really good. That's really good.
Really
but yeah, no, I think that's, I mean, obviously that from my perspective, I had a lot of inpatient treatment, and it does, I completely get where you're coming from in terms of the fact that there is no alternative at the moment. But if we can move to that sort of outpatient model, that's definitely a good goal to work towards. Definitely.
It's a big plus. I think in the areas of acute myeloid leukemia where we do have effective treatments, there is this focus on de-escalation. Can we give less treatment or treatment in an outpatient with the same effect? And I think that's another really important strand of research. I couldn't agree with you more. And we hope that with similar new drugs coming through, that we'll be able to move towards effective oral treatments, a bit like they have in chronic myeloid leukemia, We're still a bit of a way
yeah.
ways from that, but you're right. There are twin benefits from these drugs. Perhaps I should have emphasized it a bit more. Seem to be active in patients who had no other options, but also they seem to be well tolerated and give them as an outpatient. Lovely.
And
that's great.
Charlie, we appreciate you need to head off, but just one quick question just from our audience is, will the treatment affect fertility? It's a question we've got from our audience.
Don't know that. It's a very good question. And you would be advising patients that it might do. But this is a different class of drugs, and certainly patients with other specific targeted therapies, we've mentioned chronic myeloid leukemia and imatinib before, there is the possibility of having children after that. So we hope that, you know, you will have less toxicity, as Charlie was saying, but we need some longer term follow-up and specific studies. The focus is predominantly now on, are these drugs working? Are they safe? Can we get them approved so that patients can see them, patients in desperate need? And then secondly, can we develop more active combinations? But the point about whether it would be gentler on patients is well made. So I'm going to leave you now and go back and see.
Thank you again for your time and everything that you're doing. We really appreciate it.
A lovely patient, another lovely patient who's benefited from a menin inhibitor, who's now had a transplant, who's very cheerful and is as passionate, I think, as we all are, that we need to be increasing the number of clinical trials done in the UK so patients do see these drugs. So thanks for your time and congratulations on this initiative, and really super to meet you, Charlie. See you again. Bye.
Thanks, Charlie.
Brilliant. And then just to our audience, if any other questions come to mind, please do submit them. And again, we'll follow up offline. So thank you for your questions so far. Charles, we're gonna move into the second part of the webinar today on advances in ALL. Again, I'm just gonna hand it over to you, and when you want me to move the slide, let me know, and I'll do that for you. Thank you.
Perfect. Thanks, James. Yeah, if we could move on to the first slide. So yeah, I mean, really following on from what Charlie was saying about new treatments for AML in the form of the menin inhibitors, ASH was also covered some quite significant advances in ALL treatment. Obviously, we've all heard of the developments in CAR T, and that's been a big thing in Europe, and that is partly covered by the following slides, but also there is a real sort of drive through clinical trials to find chemo-free, less toxic approaches to treatment for very hard to treat subtypes of ALL, particularly the Philadelphia positive ALL, which I think we will come on to on the next slide, please, James. So yes, so PH plus ALL, Philadelphia positive. So it's the name of a subtype of ALL where a particular genetic change has taken place. As you can see, parts of chromosomes 9 and 22 swap places, which is, you know, something that's quite common in acute leukemias. That kind of is the trigger for many acute leukemia. I think most, if not all, acute leukemias, where you see a chromosomal swap, and that triggers the generation of leukemia cells. So as a result, in this particular genetic subtype, the chromosome 22 becomes shorter, and that is known as the Philadelphia chromosome. It contains, as you can see, it contains new genetic instructions, and that leads to the development of ALL in this instance. Next slide, please, James. So basically, as I said, this is a particularly hard subtype of ALL to treat. At the moment, relapse rates are pretty high for that. And so the aim of this particular study was to find a chemo-free effective treatment for PH plus ALL. So as you can see, the study involved 151 adults with newly diagnosed PH plus ALL, and it involved the use of chemo-free treatments called TKIs. So there's a targeted therapy called ponatinib, and then a type of immunotherapy called blinatumomab. Sorry for my pronunciation of that. They're pretty difficult to pronounce, these medical terms, as I'm sure you know. And as a result of the trial, or the aim of the trial, was to see if the combination of non-chemo treatments can improve remission rates and also reduce relapse rates, which, as I was saying, is very important for this particular subtype of ALL, because at the moment, even with chemotherapy and all the toxic side effects that intensive chemotherapy has, PH plus ALL is very tricky to get rid of. And as you can see, the average age of people in this clinical trial was 57. 27% were age 65 or older. So again, this kind of therapy would probably be more of use for older patients who couldn't handle the type of intensive chemotherapy that perhaps younger patients would be able to handle better. Next slide, please, James. So, as you can see, a high-level view of the results of the trial. 96% of those in the trial had a complete remission or near complete remission by the end of the first treatment phase, which is obviously extraordinary, is a really good result. 95% of patients were still or predicted to be alive 12 months after treatment. Again, fantastic, considering how this treatment is nowhere near as toxic as traditional intensive chemotherapy. And a total of 4 patients relapsed after an average of 5 months. So obviously, as we saw before, the trial included 151 patients, and only 4 of those relapsed after 5 months, which is obviously a very, very positive result. Next slide, please, James. So yeah, now we come on to side effects. Clearly, 57 severe side effects were recorded in 40 patients, so probably slightly less positive news. The most common of these were infections and heart-related issues. Compared with traditional intensive chemotherapy, clearly those are also side effects of that. So probably not surprising that these side effects were recorded, but obviously 40% is still quite a sizable proportion of those involved in this trial. But it seems that adjusting the dose of the ponatinib in older patients tended to prevent or mitigate the severe side effects outlined there. So that does seem to be a way that those side effects could be prevented, which is good. 16 patients went on to have a stem cell transplant. So again, not a massive number of that trial, of the total number of people in the trial, but that does suggest that an additional form of treatment was needed after that. And unfortunately, 7 patients died during the study. Obviously, that's not a massive number of patients within the trial. Naturally, the type, as I was saying earlier, the type of ALL that this trial covered is particularly pernicious. It's not very easily put into remission, and relapse rates are high. So I suppose you can kind of expect a number of relapses and unfortunately deaths as a result of a diagnosis here. But it's very clear from the results of this study that this treatment seems to be as effective, if not more effective, than traditional chemotherapy, even if it has to be complemented by other traditional treatments like stem cell transplants. And it's also clear that where these patients are older and who might not be able to tolerate the strength of traditional chemotherapy, it's it's a preferable alternative in that sense. But yeah, next slide, please, James. So yeah, key takeaways. I think I've covered some of these already. It's a promising new approach for treatment. Combining ponatinib and blinatumomab resulted in higher remission rates and long-term survival, and reduced the need for transplants if it didn't quite get rid of the need altogether. But obviously that is a very positive step forwards. As I said, seems to be a preferable treatment for older patients with pH positive ALL, and that's all to the good. Again, as we were coming back to something that Charlie said with the menin inhibitor trial, this is still very early days for this particular clinical trial, so longer term follow-up is needed. But it does seem that this combination of drugs seems to be an effective treatment for people who might not be able to tolerate more traditional chemotherapy-based treatments. So next slide, please, James. Thank you. So coming on to the second study that was covered at ASH, CAR-T, obviously, for people who don't know, it stands for chimeric antigen receptor T cell. It's a new type of treatment. It has been in the news a bit recently, certainly in Europe. I believe Germany have just adopted CAR-T more widely in their healthcare system. I know the NHS in the UK are certainly trialing it in certain main sort of hubs across the country. But it's a new type of treatment, and it's been approved for various different types of blood cancers, including ALL, multiple myeloma, and lymphoma. It's basically where the patient's own immune cells are modified, and then they're put back into the patient. And as a result of the modification, the cells are better able to recognize and attack the cancer cells. And in this case, we're talking about leukemia cells. But it's, again, an alternative to more traditional chemotherapy treatments. So next slide, please, James. This particular type of CAR-T is called obcapitogen autoleucel, or OBSEL. It's a type of CAR-T. It was approved in November for adults with relapsed or refractory ALL. And yes, as you can see, preliminary results for this clinical trial were presented at ASH, which we'll go on to now. Next slide, please, James. So again, 127 adults were involved in this clinical trial. The aim of the study was to see how well OBSEL worked and how safe it was. The study carried out in-depth testing of how many cancer cells remained after treatment. So coming back to MRD and MRD negativity, which is the gold standard that hematologists and other healthcare professionals look out for when they want to make sure that a patient is going to be in long-term remission. And so the study also showed whether deeper MRD responses were linked to better treatment outcomes. And obviously, in general, that tends to be the case, but this study was, I suppose, trying to put a number on or evidence to back up that hypothesis. So next slide, please, James. So yeah, as you can see, 76% of the patients on this CAR-T treatment had no visible signs of leukemia in peripheral blood or the bone marrow after an OBSEL infusion. So that's pretty good going. But even better is that 84% of those patients in remission were MRD negative and were in quite a deep state of MRD negativity, which meant that, as I said, the likelihood of them relapsing is much reduced. So for 84% of those patients who went into remission to be in MRD negativity, where there's no evidence of any sort of leukemia cells, not only in the peripheral blood but also in the bone marrow, was, suggests a very effective treatment option in obe-cel CAR T. Next slide, please, James. So the MRD negativity, patients tend to live longer. So after 21.5 months, 70% of those in deep MRD negativity were alive, compared to only 16% in less MRD or with a lesser MRD response. So again, very positive news. And as you can see, on average, people in MRD negativity who were completely leukemia-free tended to be leukemia-free for longer as a result of their MRD negativity. So 18 months for people with a deep MRD response, compared to 5 months in patients with a less deep MRD response. So again, it really does, I suppose, these results prove that MRD negativity and a strong MRD response to treatment is the gold standard in terms of guaranteeing not only long-term remission, but overall survival, not only within sort of 1-2 years, but also longer periods of time. And the gold standard, certainly for AML, and I think ALL as well, is if you're MRD negative for about 5 years on average, your chances of relapsing are almost zero, which is really what we're aiming for. But yes, next slide, please, James. So yeah, the key takeaways: obe-cel CAR T therapy resulted in high remission rates for our B-cell ALL. It also achieved a deeper MRD response, and again, as I covered, longer lasting remissions and higher survival rates. And that, as I say, is the gold standard when it comes to acute leukemia treatment. And the fact that this treatment seems to increase the likelihood of a deeper MRD response, I think, is probably the most important takeaway from this. Next slide, please. So what does this mean for patients? Clearly, coming back to what we were talking about earlier, the fact that CAR T tends to be less toxic than traditional treatments, while retaining, or if not bettering, the efficacy of traditional treatments is great news for patients. They're less likely to develop some of the more severe side effects of chemotherapy and the long-term side effects, which ultimately contributes to quality of life amongst these patients whose leukemia-free, MRD negative status will hopefully keep them disease-free for longer. PH plus ALL, newer TKIs like ponatinib, again, improving outcomes, reducing the need for intensive treatments, which again not only guarantees survival for longer, but also improves quality of life no end, which I think is really the key takeaway from this. And for relapsed and refractory disease, obe-cel seems to again guarantee leukemia-free, disease-free living for longer. And again, that's great news for patients, and particularly for certain types of ALL like PH plus, which are more pernicious and tend to relapse more easily than other types of ALL. The fact that this particular CAR T therapy guarantees longer periods of time in remission and reduces the chance of relapse is really positive news. And going back to the older patients that were taking part in this study or in the PH plus study, the fact that this treatment is more accessible to them and ensures that there are fewer sort of longer term toxicity side effects, I think really will help improve survival rates among older patients. And I suppose we mustn't forget that the majority of people with acute leukemia tend to be over the age of 65. So really, new treatments with aiming to improve not only patients' experience of the treatments, but also longer-term survival rates are really important, I think, going forwards for acute leukemia research. Next slide, please, James. And yeah, again, going back to the patient, as I was saying, older patients, can't withstand perhaps the intensiveness of traditional treatments. So these treatments are much better suited to their needs, but also better suited to younger people who are diagnosed with acute leukemia, so that, for example, they don't have to spend as long in hospital if or don't have to suffer particularly bad side effects over a longer period of time. And as I was saying earlier, that all comes down to quality of life, and the goal of not only patient advocates but also hematologists, and we hope anyone involved in the work of acute leukemia or any type of blood cancer treatment, is to not only ensure disease-free survival but also maximize quality of life for these patients. So I think these clinical trials definitely show that both of those have been targeted, and both of those are improved with these new treatments coming on board. I think that's the last slide, James. I don't know if there is another slide.
And
so
thank you
yes,
so much, Charles, for
no
stepping
worries at all.
in.
But if there are any questions that anyone has, obviously I'm not a healthcare professional myself, so I won't be able to go into the technical details so much. But if there's any sort of patient-focused questions, I know we have a couple of questions there, Catherine. So are these new drugs the way for a better quality of life? I'm hoping that this second part of the presentation has kind of answered that actually quality of life does improve with less toxic non-chemo based treatments. But yeah, so I would say that's the clinical trials that were out showcased at ASH show that these alternative treatments are much, or tend to be much better for quality of life. And the second question is around obe-cel CAR-T, whether that's better than other forms of CAR-T, which I think is probably one of those questions that I might not be able to answer, but I'm sure, James, you can take that away and possibly we can answer at a later date.
Yeah, exactly. So what we'll do is we can save the questions down, and we'll get a written response by a HCP, and we'll upload that question with the answer along with the webinar when it gets uploaded to Alan's website. I can see another questions come in, and again, just encourage everybody to keep asking the questions because they will get answered.
Definitely.
Yes. And again, I just want to thank you, Charles, for obviously stepping in and taking that presentation late notice. Obviously, with clinical practice, sometimes these things happen, and really appreciate your flexibility. So I can see there's more questions coming in. One from which again, I think it would be wise, Charles, if we handle them offline.
Yeah, I think so. Yeah.
Appreciate we've got 15 minutes left. So I think we could give some time back today. I would like to just use the time to also mention that today was highlights from ASH, but there are full reports, full infographics, which lovely diagrams and pictures, which go into a lot more detail on some of the sessions and some of the posters at ASH. So if you do want to go a little bit deeper, please do visit Alan's website, and there's some brilliant materials available. I know, Charles, we spoke about it at the start. You've taken a look at those as well.
Yeah. No, there are some very good materials on the Alan website. And I believe we're also posting some of the infographics on LinkedIn as well, if you're on LinkedIn. So, absolutely. This webinar has really just touched the surface of some of the developments that were showcased at ASH. So it's really well worth looking at our website to find out a bit more. And yeah, no, I think hopefully you're all aware of what the work that Alan does and what we're doing in terms of in terms of this year, our strategy in terms of this year. We're hoping to have an AYA based session at EHA, the EHA Congress in June, which I'm very much looking forward to. And again, that will be around the impact of treatments on people's mental health and well-being. So I'm really looking forward to a year of us really focusing on not just the efficacy of treatments in guaranteeing sort of long-term survival and remission, but also improving quality of life, as we were saying, of patients who are going through these treatments. So yeah, no, I'm really looking forward to some of the work that we're going to be doing as Alan over the coming months.
Yes, very much look forward to the EHA. Brilliant. June will fly by. So
yeah, it definitely will.
Again, just want to thank everybody for the questions that have been coming in, and we will, like I said, save them down and respond to them. We'll get HCP to write a really good response. So thank you, and apologies we can't do them live on this webinar, but we'll get there. And again, there's a compliment come through. Charles, brilliant. Thank you again.
Thank you, Sophie. Thank you.
I've learned a lot today, and I'm sure everybody else has. On that note, I'd just like to thank everybody for joining, and I wish you all a very successful 2025. And yeah, it's been a privilege to host this session today.
Thanks a lot,
Everyone.
Thank you.
Bye-bye.